But I'll do my best. Really nervous and emotional. But yeah, I'm from Sweden, and my son Edvard, he was born after a completely normal pregnancy and delivery in January 2021. And he was perfectly healthy until he was 6.5 months old. He then developed a rash, and then 2 weeks later, a fever. And after just over 2 weeks with a fever, he was admitted to hospital. And lots of tests were taken, and genetics was also done, the whole exam, but without finding an explanation. But as secondary findings, however, a gene mutation that can cause cardiac arrhythmias, Brugada, long QT syndrome, was found. And so was a gene mutation that can cause or is linked to variable immunodeficiency. But he has no signs of it, and his immunoglobulin are normal. But after 3 weeks in hospital, Edvard was put on Kineret, or anakinra, 2 milligrams per kilo. And he responded well to it at first, but after about a week, he went into MAS, and his ferritin went up to 88,000. He was treated with dexamethasone according to the HLH 2004 protocol. But the fever did not go away until the dose of Kineret was increased to 10 milligrams per kilo, divided into 2 shots per day. And he was hospitalized for almost 3 months, and he suffered both pneumonia, sepsis, and a blood clot during that time. And only a month after we came home from the hospital, he became ill again. He became as if paralyzed, and he could not oxygenate himself. So he was put on a ventilator, and after many tests, we found out he had botulism, a really, really rare condition. And we don't know how it happened, but doctors believe his immune system played a role on it. And this led us to spending another 2 months in ICU, and afterwards a very long period of rehabilitation followed. And he was then stable with normal labs and no clinical symptoms for about a year. He was treated only with high doses of Kineret. But he then contracted COVID-19, which triggered another relapse. And he had smoldering MAS for a few months, which then developed into full-blown MAS. And there a long, unstable period began, despite high doses of prednisone and anakinra, or Kineret. And we had read several articles and patient stories about lung disease, and we realized that Edvard met several other risk factors. He had young age of onset, recurrent MAS, hypereosinophilia, only systemic. So after a long time of raising our concerns, we finally got a CT scan in June 2023, and it showed ILD, and a bronchoscopy showed PAP. And when this was discovered, they made an attempt to switch Kineret to Xeljanz from day to day, but he went into MAS in 36 hours. So they stopped the Xeljanz and returned to Kineret in combination with high doses of prednisone. But he got more and more clubbing, and his labs were bad. His hemoglobin was below 80, you might say 8, and he was pale and tired. But after his doctor consulted Gosh in London, baricitinib was added. And he's now on 4 milligram baricitinib and 150 milligrams Kineret per day. And he also takes Bactrim twice a week as a prophylaxis. And he has been able to wean off of the prednisone completely, and his labs are completely normal, except for IL-18, which has, however, decreased with each testing. The first time it was tested in July 2023, it was 165,000, and now it's down to 38,000. And he has no symptoms of his lung disease except from clubbing, barrel chest, his chest points outwards, and a slightly faster breathing than normal. But his oxygen levels are completely perfect. It's 98 during both day and night. But because of all the steroids, he has lost some of his growth. But overall, however, he's doing really well after baricitinib was introduced. And the latest CT scan showed status quo, so it's stable. And he goes to kindergarten, is not sick more often than his friends. And he's, a very happy and active kid. And you wouldn't believe he's sick. Yeah, so that's our story.
He's still not growing.
Yes, he is. Since we stopped the steroids, or since he became stable, he has grown a bit. So a few centimeters in a couple of months, despite baricitinib.
Can you mention the concerns about some fibrosis and they have to be checking here?
Yeah, they have done a biopsy and bronchoscopy, and they found some fibrosis. Most of it are inflammation, but he has some fibrosis already.
Thank you.
Okay, thank you.
Okay, good morning, everyone. I'm going to present some data on lung disease in still patient from the European experience. So, as MAS SJIA working party in the context of Pediatric Rheumatology European Society, we decided to understand the burden of this complication also in Europe. So, we collected data from 61 patients with still disease complicated by lung involvement, following 21 pediatric rheumatology centers in Europe. So regarding the clinical characteristic, the majority of the patients were Caucasian and half of them were female. The age at the still disease onset was a little bit higher compared to the cohort already reported with age of 7.2 years. This probably is due to the heterogeneous of this cohort. The lung disease onset around 2 years after the diagnosis of still disease. We have only 3 patients with trisomy 21 in our cohort. The still disease course was chronic persistent in the half of the patient and polycyclic in 43% of the patient. 74% of the patient had arthritis at time of still disease onset, and the majority of them had active still disease when the lung involvement was diagnosed. The majority of the patient had history of MAS with more than one episode, so with a recurrence episode of MAS. Regarding the lung fissures, the majority of the patient had interstitial lung disease. The acute digital clubbing and cough were the most common clinical manifestation at onset. Most of the patients receive a chest CT with septal thickening found in the majority of the patient. A small percentage of patients receive a bronchoalveolar lavage and lung biopsy. Unfortunately, we don't have data regarding IL-18 levels for all the patients, but for the patient that we have, we found high IL-18 levels at onset, still disease onset, and particularly at time of lung disease diagnosis. Some patients had also hypereosinophilia, so we found a percentage of patients who had a number of eosinophils higher than 1,000. Particularly again at time of lung disease diagnosis. And regarding the HLA-DRB1, we found that 76% of the patients carry the 15 allele and 41 the 11 allele. So what about the treatment? 80% of the patients in the European cohort had received IL-1L6 inhibitors before the diagnosis of lung disease, and 44% of them had a drug-averse reaction to one of these drugs. We have 12 patients in the cohort that did not receive any IL-1L6 inhibitor before the lung disease diagnosis. All of these patients had interstitial lung disease. Half of them had recurrent MAS and active MAS at time of lung disease diagnosis. Half of them were admitted in ICU and 2 died. After the diagnosis of lung disease, the patient receive any kind of treatment, actually. So as you can see here, the treatment were very heterogeneous among the entire cohort. The majority of the patients receive glucocorticoids, and they receive cyclosporine, MMF, methotrexate, anakinra, canakinumab, tocilizumab. 7 patients receive emapalumab, 3 etoposide, 1 patient sirolimus, 4 patients MAS-H05, and 7 patients receive hematopoietic stem cell transplantation. About the outcome, we found that half of the patients had still disease in clinically inactive disease at time of last of follow-up. 38% had an improvement of the lung disease at the last follow-up, and 38% the lung involvement was stable. 34% of the patients developed lung disease complication, as hypoxia, oxygen supplementation, and pulmonary hypertension. Half of the patients were admitted in ICU, and 11 patients in our cohort died. So as you can see, the casuistics is quite heterogeneous because we collected patients from many different pediatric rheumatology centers. Some of the patients obtain a delayed diagnosis, so this is probably why the cohort is so heterogeneous. And now I'm going to present some data from our small cohort in Rome, and it's just our experience. At this moment, we are following 6 patients with still disease and lung involvement. Half of these patients are female. The age at disease onset is lower, as you can see, compared to the entire European cohort, is 4.5 years, and lung disease developed almost 1 year later. We don't have patients with trisomy 21. The majority of our patients had MAS, actually 5 out of 6, and 4 of them with recurrent episodes. Half of our patients had hyperosinophilia, and L18 levels are significantly higher in all of our patients. 5 patients carry the HLA-DB115 and 5 the HLA-DB111. It's not the same patient, because we have 1 patient who doesn't carry the 15 and 1 other patient who doesn't carry the 11. So about the treatment, 3 patients in our cohort receive anakinra before the lung disease diagnosis, 1 anakinra and canakinumab, and 1 anakinra and tocilizumab. So only 1 patient in our small cohort was exposed to L1 or 6 inhibitor before the lung disease diagnosis. 4 patients had a drug reaction, 3 to tocilizumab. 1 patient developed the reaction after the first and the third administration of tocilizumab, and 2 patients developed the reaction before the reaction after the lung disease was already diagnosed. So what we did after the diagnosis of lung disease? Actually, everything, as you can see here. We have started to understand and follow this patient actually since 2017. And we actually don't know yet which is the best treatment for them. So we have tried different drugs. All of them are on IL-1 or 6 inhibitors. Some of them already was receiving cyclosporine, and we shift from cyclosporine to MMF in 3 patients. We have 1 patient sirolimus, 1 on ruxo, 2 on emapalumab, and 4 patients on MAS-H05. So regarding the outcome, we can't conclude anything. I just reported our experience, and we can discuss together. So we observed that 1 patient improved with IL-1 inhibitor and MMF, so with a kind of smoldering treatment. 2 patients improved with MAS-H05. 1 patient remains stable with emapalumab treatment, and 1 patient worsened despite MAS-H05, and she's now on emapalumab. And 1 patient actually developed lung disease when he was already on sirolimus treatment. Fortunately, no one of our patients developed lung disease complication. None of them is on oxygen supplementation, and none of them died. So, and that's it. This is my last slide.
So on to Dr. Lauren Henderson from Boston Children's, if we can bring her up on Zoom.
And then we'll try to have a few minutes for questions, and all the panelists from this session, speakers from this session, if they can come up, though I'm not sure we'll be able to accommodate everyone, but we'll figure it out.
All right, I'm very pleased to be talking with you today about recognizing and treating lung disease and systemic JIA. Thank you for inviting me. I'm very sorry I couldn't be there in person. I'm expecting a baby in a week, and my OB would not let me travel to DC. Here are my disclosures. And so as everyone has talked about here today, lung disease is increasingly recognized complication of systemic JIA. And we can see here the experience from Cincinnati from Grant Schuler's paper in 2019, where you see like a rapid increase in the number of SJIA lung disease patients that were referred to that center and also seen at that center. Also, as Grant has mentioned, the prevalence of SJIA lung disease has really ranged widely from low numbers in Europe, in some cohorts around 1%, to very high recent reports in China of up to 20%. And of note, in China, many of those patients developed lung disease before exposure to biologics. In the United States, I think many of the reports are, around 6 to 10%. So this really means that lung disease is not super rare. It exists in our population. We need to be able to identify it. Many of our patients are asymptomatic at onset, and affected children are young and have difficulty reporting their respiratory symptoms. And I think all of these points argue to the importance of having a systematic approach to pulmonary screening in systemic JIA. And what this systematic approach would give us is a better understanding of the true spectrum and burden of disease. And then the holy grail, obviously, is for us to be able to identify patients early, initiate treatment, and prevent irreversible damage. And I want to talk about 2 cases here. So this is work by Barbara. She was a resident at Boston Children's and now is a rheumatology fellow at HSS. And she actually looked back and described a cohort of patients at our institution that have some of the worst lung disease that we encountered. And these were all patients with congenital heart disease. So this is case 1. This case was cared for at our institution quite a while ago, where lung disease was not as well recognized. This child was young, had onset before 2 years, had all the risk factors, recurrent MAS, high IL-18, the HLA DRB115 phenotype. And ultimately was having recurrent episodes of MAS, developed an oxygen requirement. It was initially attributed to pneumonias or infections, but eventually got a chest CT and was diagnosed with lung disease. And so you can see a lot of damage had accumulated. We were behind the 8 ball already because the child had an oxygen requirement. And despite really maximal therapy, repeat imaging at 6 months showed progression. So that is kind of like what we want to avoid. What would be more ideal would be a case 2. So this is another child, again, a young child, onset of systemic JIA before 2 years, had an episode of MAS, had high IL-18, did not have the HLA allele, and was recognized very early. So had just mild coughs that lingered with viral infections, but the clinician was very astute and worried about lung disease, referred to pulmonary, and got a chest CT with some findings, but not devastating findings. The regimen was changed, tacrolimus was added to a regimen, and 9 months later, her chest CT was stable. So, we have to, put it all out there that it could be that this first patient was always going to progress. It was a progressor, and nothing we could have done could have made it better. And case 2 may have always been a patient who would just have stable disease, and that screening might not make a difference. But the alternative is that screening might make a difference, and that identifying these patients earlier will allow us to intervene. And I think we have to hope that that is the case, and at least for now, pursue that approach. And so to do that, this is work that was led by Holly, who is a very talented fellow at our center. Because there's so little evidence on how to go about for screening for pulmonary disease in SJIA, we decided that the best approach for our group was to develop some consensus among the clinicians who care for patients with systemic JIA and develop a very clear strategy. So I think different centers could develop different strategies. I think what's most helpful is having a systematic approach that you're reevaluating at your center to see if you're capturing the patients that you need to capture. And so to do this work, we convened a multidisciplinary group at our single center, mostly rheumatologists, but this also included pulmonologist, a stem cell transplant physician, and we had representations from a patient's family. And we went through a structured consensus process where we assembled a work group, reviewed literature, drafted an algorithm, had the work group members vote on statements that helped us develop the algorithm, held a consensus meeting, revised the statements, voted again, approved the algorithm. And then we did one more round of voting to add one additional statement. And so this is the algorithm that we're using at Boston Children's. Again, not saying that this is the exact way everyone needs to do it, but this is what we have come together as a center to try to do more consistently. So in our algorithm, we're starting with a patient often with new onset systemic JIA, or someone with systemic JIA that you don't know that they have lung disease or not. And our group gained consensus that we want to track IL-18 levels serially. We also check CXCL9 until it normalizes. And we do HLA type all of our patients. So there was a lot of kind of back and forth on this in our consensus group. As we know, this the HLA DRB115 allele has been associated with hypersensitivity reactions by some groups. At our center, as has been mentioned, a very high frequency of patients have this HLA allele, and it seems to be associated with severe disease. This association is, when we look back and studied, more patients with this allele had MAS before any drug was started, pre-treatment. And so we felt that this could be a marker of disease severity, and we wanted to track it. We initiate first-line treatment with an IL-1 or IL-6 inhibitor. And then our approach was to try to identify what we thought were risk factors for lung disease in our patients. And if a patient has any one of these risk factors, we recommend they're referred to see pulmonary. So those risk factors are young age of onset, having the HLA DRB115 allele, trisomy 21. And then for number 4, we didn't vote on this, but I added it based on our recent experience, is a history of congenital heart disease, based on when we looked back at our cohort and saw that a lot of patients had very severe lung disease with congenital heart disease. High disease activity, so being admitted to the ICU for systemic JA, having MAS, having labs like high IL-18. And so for us, high IL-18 isn't a particular value that we gave a cutoff, but typically these patients, are hundreds, thousands, 200,000, maybe 50,000, but very high levels. Patients with a new atypical rash, patients with eosinophilia. Again, when we look back at our cohort, we found that patients with eosinophilia had markers of more severe disease, particularly measured as developing MAS before any treatment was started. Anaphylaxis to any drug, respiratory symptoms, and abnormal pulmonary exam or clumping. So if a patient has any of these features, we decided our approach would be to play it safe and refer them to pulmonary so that a pulmonologist could assess them. And there they get, in pulmonary clinic, they get chest x-ray and PFTs. And so the PFTs that our pulmonary group likes to do is spirometry, lung volumes, DLCO, and then either a 3 or 6 minute walk test, depending on the age of the child. And so if the pulmonary evaluation is normal, the plan is really close follow-up, at least every 6 months, often every 3 months, with pulmonary and rheum to make sure nothing's progressing, nothing's changing. And then if there's an abnormal pulmonary evaluation and or uncontrolled disease, our recommendation is a chest CT with BAL. Now, there was some discussion in our group, should everybody who has a risk factor get a chest CT? And it was felt that, that does expose children to radiation, and sometimes they have to be sedated, and that some of that chest CT could be left to clinician discretion if they were going to follow the patient very closely. If they have uncontrolled disease, we recommend modifying treatment to gain control of the disease, hopefully. And then these patients really need to be followed very, very closely every 2 to 3 months or more frequently to make sure that the lung disease is not progressing. So that's the algorithm that we developed at Boston Children for pulmonary screening. And then I was just asked to talk a little bit about our treatment approach to patients with systemic JA lung disease. Unlike the screening guidelines, our center hasn't developed like a systematic approach that everyone does. I can share a little bit of what I've done. My goals if I see a patient with systemic GA lung disease is to get full disease control the best I can. So resolution of clinical symptoms, fevers, rashes, arthritis, hepatosplenomegaly, serositis, MAS, eosinophilia. And as much as I can, normalization of SJIA, MAS markers. Again, I know that we had a lot of discussions about IL-18. Like Alexi mentioned, I think IL-18 of a couple of thousand, I'm probably okay with, but someone with an ever increasing level of IL-18, I feel that that is not disease control. And especially if their IL-18 levels are high, like tens of thousands, then I think that my impression is I don't have disease control. And then the way that I treat is there's not necessarily a way that I do it every single time. I just constantly am changing what the patient is getting until we attain disease control. So typically starting with a biologic DMARD, mostly anti-IL-1s with steroids. As much as we want to minimize steroids, about to have to start it if they have lung disease to get control. Almost all the patients that I have on an IL-1 inhibitor on methotrexate at least, or cyclosporin and tacrolimus. Next step often would be to add on a JAK. And then if that doesn't work, I often will go to anti-interferon gamma emapalumab. I haven't combined emapalumab and JAK inhibitor, but I have combined it with an anti-IL-1 and tacrocyclosporin. And then for treatment, I think it's very important to have a skilled pulmonary partner. So at our institution, we're lucky to have Alicia Casey, who's fantastic, but we've had some patients follow it outside pulmonologists who don't understand the disease, how subtle it can be, how closely you have to screen, how quickly you have to move. And it has been detrimental. So almost all of our patients we funnel towards Alicia Casey or one of our close colleagues. And there's serial PFTs and chest CTs, echoes to make sure that there is not progression. And then when to think about stem cell transplant, I think part of it is laying the groundwork at your center at the beginning to just establish a relationship with a team that's willing to manage systemic GA lung disease, that understand it, understand that if you have a very sick patient who's progressing, that they have to work very quickly. And we've been able to do that with Holly and Susan at Boston Children's. You can always consider an early referral for education, HLA type being donor search. And then when I really think to very much push for referral are patients with many risk factors, patients where despite my best efforts, I cannot control disease, patients where the lung disease is progressing, and patients with comorbidities that if the lung disease worsens, they won't be able to go to transplant later. So I just want to thank everyone who's involved, particularly Holly, Barbara, Joyce Chang has helped us with this effort. Fatma's thought about these patients a lot too. Alicia Casey and Susan, and in particular, our patients who participated in developing the guideline panel and inspire this work. So thank you very much.
So we'll take 10 minutes for some question answers for all the speakers in this last session, maybe starting with some questions if we have them. I was thinking of having everybody come up here, but we might not have time. So questions? Any from the, yes, Alexi has a question. Let me give you that.
I have lots of questions, and I will start with Claudia. Yes. First question, I was paying attention, all the slides today describing epidemiologic data on this refractory patient population. There is a marked female predominance, at least 60%, if not more. So do you see the same thing? My next question is, in the US, we started seeing this lung disease roughly in 2010. And then the sort of massive uptick in the numbers of new patients. We have impression here in the US that in Europe it was started happening a little bit later. So you did not mention the dates of the diagnosis of the lung disease in your patients, in your slides. Could you comment on that? And my other question is, in Cincinnati, I would say if I think about the last new patients, new onset disease, patients with systemic juvenile idiopathic arthritis that we've seen over the last year, more than half of them develop not that classic Still's disease rash, but they develop highly pruritic, fixed rash that on the biopsy looks a little bit like neutrophilic dermatosis. Pierre Cartier published a beautiful paper just a couple of years ago showing that, in fact, that phenotype is increasing in France as well. And the presence of this pruritic rash at disease onset is predictive of a very difficult course that includes recurrent MAS as well as the lung disease. You didn't mention anything about the nature of the rash in your population.
Okay, thank you, Alexi. So regarding the first question, so in the European court, first patient was diagnosed in 2017. So this is what was the report, and also in our experience in Rome. So we diagnosed the first patient in 2017. I don't know if the complication started later or because we had started to look for this complication. I don't have an answer.
You miss it.
Yeah.
It's there, it's there.
No, I'm not agree. Because so pediatric patients are not always symptomatic. If you don't have clubbing, sometimes you can't diagnose the complication. We don't look for lung involvement in this patient, at least in the past years, not now. Now we are more focused on this complication, and we perform high-resolution CT in young children, so we are very more focused on this. But in the past, I'm not sure that we diagnose this complication every time. So this is my opinion. So regarding the rash, it's true. We see the same. I don't know exactly how it happened in Europe because it's more difficult to collect this information in a very clear way. But we can try to figure out. But regarding our small cohort in Rome, yes, all the patients have a different kind of rash, very itchy, more extensive. Sometimes it's a kind of a macular papular rash, and yeah.
And one more question. GI involvement. So the other thing that we started seeing in Cincinnati. Yes,
Yeah.
gastrointestinal involvement. It's something new. If you look at the diagnostic criteria of systemic GIA, it's an exclusion criteria. Suddenly, over the last year, I probably recall at least 3 or 4 patients, correct me if I'm wrong, who had pretty impressive GI involvement. And these are the patients exactly with the phenotype that we are discussing here.
Yeah.
Are you seeing the same thing?
In the European court, we didn't ask for this, but I think we need to go back and ask them if they have, this patient have this kind of involvement. And I can say that in our court, we have at least 3 patients with smoldering or more severe GI involvement. Looking at the data, I found that one patient had several important GI symptoms at onset before the SJIA diagnosis. So probably it was this kind of manifestation. And the other 2 patients had GI involvement. So half of the patients.
Thank you for the presentation. I have a question for Lauren. Just to let you know, I'm Bruno Fotrel, so I'm an adult traumatologist. I'm not completely familiar with SJIA, but with adult patients, yes. And I have a question about your therapeutic algorithm for patients with interstitial lung disease. For me, methotrexate and cyclosporine are not on the same level. And so it seems to me in this very serious patient, difficult to advocate for methotrexate, which is not a so effective drug in this patient. And my second question is about, don't you think that JAK inhibitor could be used before cyclosporine in this patient?
Yeah, when I was asked to write down what I do, I think it really depends on the patient, and it's very, very variable. Increasingly, like any SJIA patient that I have an I-1 medication, I start methotrexate. Like not even knowing that they have lung disease. And then the next step is either if they have lung disease, tacro or a JAK, kind of depending on like the side effect profile. So I've done different things in different patients. That's not meant to be like a fixed algorithm.
We have Mike.
Hi, I'm Mike Umbrello from the NIH. I want to follow up a few of the questions that you had asked, Alexi. So you had asked about the existence of lung disease predating 20 teens when you started to observe it at Cincinnati. And Paul, you had said before that it's your impression that this is not an emergent phenomenon, but that it's always been there. And this is the thing I've been racking my brain about. And looking back at the literature, I don't see real evidence that it was there. And I'd like to talk to the people that were there, but we can't necessarily talk to many of them. But as Alexi said, there are features of this that are so striking, I have a hard time imagining that it would be missed, that people wouldn't have been dying from this. They would have had clubbing and lung disease. So in my mind, that emergent thing is just a critical question, and I'm curious to understand the evidence or to support to suggest that it existed before 2000 or 2010 in your mind. You said it wasn't, yeah, that's what I was wondering.
Again, being the oldest one, can I say something?
Yeah.
I think it was there. There are a few cases here and there. Very rare, extremely rare. I remember the sick kids cohort having a couple of them before 2000s in decades. So I think you are right. I think it's emerging. And I think, Alexi, it's emerging because it's difficult to miss it. But it was there as a phenotype of the disease, okay? Very rare.
And thinking that there is a potential genetic underpinning of it, Fabrizio, you would think that although there might be an environmental contributor that's participating,
Absolutely.
that the genetics in the most severe cases could have been unfurled in the absence of the thing that we might
Any
be thinking is
environmental
driving.
thing,
Yes.
whatever that is, yes.
So there's lots of moving parts, Mike. So remember, if you don't have to be old, actually, you can just open the older editions of Cassidy and Petty. The mortality for macrophage activation syndrome was described as 10%. It's no longer 10%, it's 0 to 1%. So it's a harsh thing to say because there's parents in the room, but many of the patients who are going on to develop lung disease are surviving and hitherto did not survive. Back in the 90s, Colin Wallace, our respiratory physician, and Pat Wu would always describe cases of Still's disease who had lung involvement. The second thing is that the main risk factor is severe disease under the age of 2. And these are the hardest patients to screen for lung disease because you're straight to CT of the chest. So there's lots of moving parts. There's also a little bit of, I think, physician hubris. There's a word. Because how could we have missed this? It's so obvious. We missed it. You know, almost said we were not screening for it. And it's not a criticism. We just weren't screening for it. So there's lots of moving parts that gives the impression, oh my God, there's an explosion of this new phenotype. And it may be new in that there's more of it, but there's more of it for many different reasons.
May I say something also? This is Fatima from Boston Children's. I think one of the things I agree with Mike I don't know if we missed it. It's possible. And also the kids who are sick or they were on steroids for a long time. I think I'm just wondering if being on the steroids somehow the disease was treated or they weren't, because in our cohort, we really didn't have a lot of, the mortality wasn't that high when we looked at the older, I'm talking about the 1999 to early 2000 years. So I wonder if there's, because of that shift from steroid, like obviously the horrible side effects. I'm not advocating to go back to using steroids, but.
And the same thing happened in the ANCA vasculitis world when some of the Montelukast inhibitors were introduced into the care of severe asthma patients who'd been on steroids or they came off the steroids and suddenly developed Churg-Strauss syndrome. Montelukast causes Churg-Strauss. No, it doesn't. You've just removed the need for steroids and the emergent true diagnosis appears. There's lots of moving parts.
Mariana, quick comment, and then Fabrizio, and then we have to take a break.
Now I feel I shouldn't ask that. It's because one thing that I was just wondering, and I see some division on people's opinions, so I just wanted to know what is the prevailing opinion. Some people feel really strongly about stopping IL-1, IL-6 inhibitors on lung disease patients, and some people continue those medications. So I should not have that. It's a quick comment. Is there... Sorry. Yes, sorry. Let's just close that can of worms and we talk about it after lunch. I'm sorry. Because one of the parents did mention that they stopped the IL-1 inhibitors. There was a recent paper that they suggested that those patients are doing better. I just wanted to know if there's experience in the room, if anyone has seen one way or another. But we can also ignore the comment if we can like move it along. Sorry.
But this is the elephant in the room. So I think we should not avoid it. And it's great that you raised the question, and we should discuss it. But I promised I had a very short question for Laureen. This is Fabrizio. Thank you very much. Did you use sirolimus or you don't?
No, for lung disease, I haven't. I've used Tapro. For my other immune dysregulations, I've used sirolimus. I don't know if Fatma's, if she's there, if she's used sirolimus. But I've used more Tapro. Just because it's similar to cyclosporin.
Yeah, I haven't for systemic. I've used for other systemic, like immune dysregulation patients. Sure.